It's just a huge honor for me to bring onto the show two of my idol, role model, legends in dentistry, Mark Donaldson, BSP, ACPR, Farm Medical, I mean, it goes on forever, and Jason H. Goodchild, DMD. I wanted to wait for the show just to see my surprise. Does the H stand for Howard? I mean, we're both bald. We're both dentists.
Yeah, we're simpatico, kindred spirits. Absolutely.
Oh my gosh. What does it really stand for?
Actually, it's a funny story. I had to give you a little background. My mother's maiden name is Husband. So, thanks for calling that out in the very first 30 seconds of our talk today. But yes, my middle name stands H is for husband. But I'm going to adopt Howard.
And my gosh, I named all four of my boys. I gave them the middle name of their moms. They're all Wells Ferrans. I thought it was so crazy that she just had to give up her whole identity and they'll be named after me because I'm the male in a dimorphic species. Big deal. But anyway, so let's start the bios. Dr. Mark Donaldson, the initial, let's go after him. BSP, that's a Bachelor in Science in Pharmaceuticals. He's got the ACPR, accredited Canadian Pharmacy Residency. He's got the PharmMD, that's a Doctor of Pharmacy, like a JD for lawyers, a Doctorate of Judicial. He's got the FACHE, Fellowship American College Healthcare Executive. He's got the FASHP, Fellowship American Society Health Systems Pharmacy. He received his bachelorate degree from the University of British Columbia and his doctorate in clinical pharmacy from the University of Washington. He completed a residency at Vancouver General Hospital and has practiced as a clinical pharmacy specialist, clinical coordinator, and director of pharmacy services at many healthcare organizations in both Canada and the United States. He is currently Associate Principal of Clinical Pharmacy for Vizient Advisory Solutions and lives in Whitefish, Montana, so I doubt he ever works. He's probably just got a fishing pole in one hand and a beer in the other around the clock. Dr. Donaldson is a clinical professor in the Department of Pharmacy at the University of Montana, clinical associate professor in the School of Dentistry at Oregon Health Science University, and affiliate faculty in dentistry at UBC. UBC is the University of British Columbia faculty of dentistry. He has lectured internationally to both dental and medical practitioners and has spent the last 28 years focused on dental pharmacology and dental therapeutics. He's a leader in the field. He's been published a gazillion times. And now we got Jason Husband Goodchild, DMD, received his undergraduate degree from Dickinson College in Carlisle, Pennsylvania, went on to receive his dental training at the University of Penn School of Dental Medicine, Philadelphia. He's currently the Vice President of Clinical Affairs at Premier Dental Products Company in Plymouth, Massachusetts, or Plymouth Meeting, Pennsylvania. He's involved in developing innovative new products and educating clinicians to improve clinical practice. He is also Associate Clinical Professor in the Department of Oral and Maxillofacial Surgery at Creighton University School of Dentistry, Associate Clinical Professor in the Department of Oral Medicine at University of Pennsylvania, Adjunct Assistant Professor in the Department of Diagnostic Services at Rutgers School of Dental Medicine, that's formerly known as University of Medicine and Dentistry of New Jersey. He maintains a private practice in Jenkintown, Pennsylvania, and he works for probably the most amazing CEO in dentistry has to be Julie Charleston. She's fourth generation, family-owned business. The only other fourth generation female family CEO is fourth generation Burkhart. Burkhart Dental Supplies is a fourth generation family-owned business. But I think Julie, I mean, I just, my God, I mean, what could you say about Julie other than she is always amazing. And go figure, she's on top of AI. I mean, right? I mean, she wouldn't settle for HTML. And we're here today to discuss how the three of us can brainstorm to marrying Melinda Gates. She's on the market. Mark doesn't have a chance with all that hair on your head. You're going to have to shave that off. But the Bald brothers, me and Jason got a chance. Jason, what should our strategy be?
Well, I think Mark's in the game too. He keeps fighting this thing. I think you should just give up the ghost and shave it off. He's halfway there already.
If Melinda said, I'll marry you, Mark, but you got to shave the head, look like me and Jason, would you do it? Or would you forego the money to keep that mat of hair on your head?
Well, my understanding is that they did not sign a prenup, so I don't actually know how much she has in the bank, although she's probably fairly well off. Like most of my answers, Howard, you're going to hear me say this often. I'll have to check with my wife.
But I'll tell you what. In all seriousness aside, you guys are both legends on Dental Town, and CE. My gosh, you came out with the appropriate analgesic prescribing for general dentists, appropriate antibiotic prescribing for dentists, interesting and useful pharmacology for dental professionals. My gosh, and then our other brother had Mythbusters, local anesthesia edition. He just came out with that recently. And local anesthesia in dentistry and considerations for mandibular anesthetic success. I mean, you've really spent a large part of your lives trying to educate dentists to be better. I want to start the first question just real quick for everyone. For Mark, is you're a dental pharmacologist for Vizient Inc. It's Vizient Inc.com. A lot of my homies listening to you right now, remember, a quarter of our listeners are still stuck in dental kindergarten school, so they probably never heard of this company. So tell my homies in dental school what VizientInc.com is.
Sure. So, Vizient Inc. It's the largest group purchasing organization in the United States. Primarily representing not-for-profit organizations. We have over 95% of the academic medical centers as our membership organizations, to include over 600 of the community hospitals, surgical daycare centers. But essentially what we do is we're a performance improvement company, a healthcare performance improvement company. And so we do two things. One is we help hospitals, again, primarily not-for-profit organizations, to get the best price at the pump for whatever widget they need in their hospitals, from pharmaceuticals to surgery beds to Band-Aids. And then once we get them the best contracting price possible on any item, the next thing we do with our consulting group, which I lead the pharmacy team on, is to help them utilize that to the best of their ability. So get the best price up front, use it most efficiently, most effectively, really improve those patient outcomes, and that leads to the best of all worlds.
And I'm not going here for politics. I don't like talking about religion, sex, politics, or violence, but I'm always curious. I do have an MBA from Arizona State University, so I'm always wondering, does a company like that, like if I was to meet Byron Job, the president and CEO of Vizient, in the hallway, and he was whispered the answer in my ear, does a country going into universal health care, does that look good for? Would Byron think that's better for his company, or would he look at that as a sliding downhill?
Byron is a very progressive, open-minded guy, probably very similar to our discussion about Julie earlier. I think he continues to recognize that there has to be change, and with change comes opportunity. The nice part about Vizient, even though we are kind of that 800-pound gorilla, as I said, the largest healthcare performance improvement company, we are very agile. And I think that the organization has done very, very well over the last, 20 plus years that we've been in business to continue to be at the forefront. So I think Byron, would embrace change. It's something that we have to accept in healthcare, and I think we've done a very good job around it.
It really scared me last week when they just banned, illegalized menthol cigarettes. I mean, everybody knows you're not supposed to smoke, but where is the rights of an individual? And if a government takes over healthcare, and they're going to find out that smoking is not the leading cause of death. It's heart disease. It's obesity. It's all these other things. I'm just concerned they're going to take away my In-N-Out cheeseburgers. I mean, where do you? I mean, how
the double?
I mean, how? And it's always that boiled frog, that slow deal where they slowly take away all your rights, and then finally you're wondering. I mean, are you serious? I live in a country where I can't smoke a menthol cigarette.
Yeah, Howard, I don't know how much you know about my history, but I just naturalized last year. So prior to coming to the States, I am a Canadian. And so, I'm used to that universal healthcare piece. I don't think it necessarily has to be as intrusive, but, we can all adapt. We can be that frog in the boiling water eventually.
Yeah, but you gotta draw the line somewhere. I mean, I still think I have the right to eat cheeseburgers and Doritos and smoke a menthol. And when I go into the universal healthcare, if that means I'm not qualified for heart, lung, and liver transplant, or I have to have a co-payment to have skin in the game, or you tax that product just to go to the healthcare system, I get all that. I mean, you got to be pragmatic, but to just sit there and say someone 3,000 miles away said you can no longer have a menthol. I mean, that's a slippery slope to losing my cheeseburgers. And if you took my cheeseburgers away, that might be the end. I don't even know where to start. So I'm going to start first with the 400-pound gorilla in the room. And that is, my gosh, I've being a dentist 3 decades is exciting because you get to see cycles, because intelligence is just, the first time you see it, it's like looking at a giraffe. And then the second time you see it, you say, oh, that's a giraffe. So it's just pattern recognitions. And I look at the game as like kind of that Pong. Remember that ping pong, that first computer game? And when I got out of school, the whole media was those mean doctors. Grandma's dying of cancer and she's in all this pain. And they won't give her a narcotic because they think she's going to get addicted and start dancing on a stripper pole, and now so they started loosening up, they started giving them out, and now it's clear to the other side. My gosh, yesterday there was a deal out that Elvis got his first pain pills from his dentist. You have all that. So now it's sliding all the way back. I saw the same thing with beer. When I was in college, every city had its own brand of bottled beers, and then they all got consolidated to just Budweiser and Miller, and now it's deconsolidating all the way back. Same thing with dental supplies. When I got out, there's several dental supply companies in every town. Then Pete Frechette at Patterson rolled them all up into Patterson and Shine, and now they're unrolling again. So it's just a back and forth swing. So where are we at in the state of analgesic prescribing for the general dentistry, which you made a online CE course on? I mean, there are militant dentists where if you lost your arm, they wouldn't give you a tile number 3 with codeine. And there's other ones that are a little more loose. But where you stand now with all that?
I'll start, and then I'll let Jason chime in, because this is actually work that we've been doing now for, wow, it's hard to believe it's coming up on 22 years, I think. But Howard, you're right. I mean, the pendulum has swung, and it's such an interesting topic because not necessarily all drugs are bad, but we always talk about the right drug, right dose for the right patient and the right procedure. And when we talk specifically about dentistry, pain in dentistry typically is secondary to inflammation. And, unfortunately, narcotics are not anti-inflammatory agents. So by simply prescribing narcotics for orofacial pain, you may not necessarily be addressing the true underlying pathophysiology of that problem, which again is related to inflammation. Now, that doesn't mean that there aren't perhaps those patients that your grandmother, as you said, where a narcotic might be indicated. But I think one thing that we learned through evidence-based medicine, evidence-based dentistry, is that, we do have first, second, third line agents. And I think what we've graduated to is understanding now that, narcotics should not necessarily be that knee-jerk reaction. If somebody has dental pain, if you do significant surgery and your patient's going to be uncomfortable for a few days, it doesn't necessarily mean that they need that, that Vicodin, Percocet, Tylenol number 3. That may in fact not be as good as the good old acetaminophen and ibuprofen combination. But let me let my colleague here jump in as well. I don't want to steal your whole show.
No, thanks, Mark. And I will chime in because I think that there's a perception of dental patients that if they get a root canal, an extraction, a third molar extraction, that will equal a certain amount of pain, and a narcotic is what they need walking out the door. And the common joke is, what's the easiest way and fastest way to get a patient out of our office? We'll write them a prescription. And so there's the perception that this dental work is going to cause a certain amount of pain, and the opioid is what is needed. And we know that. And again, I'll also say something else about dentistry, right? I think that there's sometimes a disconnect between what we call evidence-based dentistry and I think what I will call what works best in my hands dentistry. So if you had dentists that have just forever written a Tylenol 3 prescription out the door for any root canal that you've done, I really think that takes the evidence base of where we are now out of the equation, because we have so much good evidence to show that mixture of acetaminophen and ibuprofen really should be first line. And it's not taking the narcotic out of the equation. It's just saying, hey, let's try this first. And if that works, that's all you need. But if it doesn't, we still have other things we can do to get you out of pain. It could be long-acting local anesthetics. It could be glucocorticoids, but it also could be narcotics as well, which means, the right drug for the right patient. Mark and I say this all the time, the rights. When you match up those, right patient, give them the right drug at the right dose with the right frequency, you can really do a lot of good. And so I really like where Mark started off with it, which is, hey, first line for dental pain nowadays should be an anti-inflammatory agent like ibuprofen. But we have other things we can try because everybody's different. We want to individualize our care.
Wow. Those are two profound answers. I want to go the same with antibiotics, and I'm not throwing my homies under a bridge because I'm a realist, and if you don't self-manage your profession, it becomes a failure, and that invites a third party known as the federal, state, and local government to come in and say, we're going to help you do what you can't do for yourselves. And it's really, which doesn't make any sense, because if you live life more than 10 years, you know that people are always hardest on their own tribe. Like, I mean, look at kids. I mean, if anything goes wrong in their life, they always first blame their mom. It's just an instinct, right? It's like, shit, it's always the mom's fault, which I agree with because I was the dad. I mean, how could it be the dad's fault when your mom, I mean, she's sitting right there. It's her fault. And I think dentists are, every tribe is much harder on themselves than others. But my God, there's a hell of a lot of dentists my age. I'm 58, and between 50 and 65, that every time they do a molar root canal or pull a set of thirds, it's a Pen VK 500 milligram, 28 tabs, and 16 tabs of Vicodin. We already talked about the Vicodin, the narcotic side of it, but just, I mean, I can give you the name of 100 dentists that do that after every root canal, and they say things like, CYA, well, it can't hurt, cover my ass, I mean, blah, 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 blah. But first of all, do you agree that there's a lot of dentists out there? I mean, obviously they never do that in Canada, but I'm talking about in the United States. Do you believe a lot of older dentists just still do that in the United States?
Yeah, there is still a lot of misprescribing of antibiotics, and I appreciate the platform because any chance I get to remind your colleagues that there really are only 3 compelling indications to ever write an antibiotic prescription. 2 are for prophylaxis, so prophylaxis in your cardiac patients and prophylaxis in your immunosuppressed patients. And then the 3rd indication is for treatment. So if somebody actually has an orofacial infection, sure, they need an antibiotic, but that's it. I mean, if you are writing antibiotics outside of those 3 compelling indications, then you are outside of the current guidelines. Now, your point's such well taken, because, why do people do this? Well, like you said, the antibiotics are cheap. Amoxicillin is, pennies a dose. And at the end of the day, it seems to work. But the problem that we have is what we sometimes refer to, Howard, as collateral damage. In other words, if patients don't really require an antibiotic, but you prescribe it because that's what you do for all patients all the time, in many cases, patients will get better without the antibiotic, but because you've added it, you could create this collateral damage, the idea that you actually start to knock down the normal flora, the commensurate bacteria that live in our bodies, and that could lead to a secondary problem, maybe fungal issues such as oral candidiasis. Maybe it could actually lead to a viral infection or a secondary bacterial infection. And I think that's part of the problem, is people have just got so used to Pen VK, amoxicillin. These are ubiquitous words that just roll off the tongue, and we write these prescriptions all the time. We give them to our kids, our family, our staff, but we forget that they're actually very, very powerful medicines. And like all medicines, they have good effects, but they also have some side effects. And those side effects have led to a problem of not only overprescribing, misprescribing, but now some of the superbugs that we have out there. And what I always try to tell people is, with this misprescribing over time, while you might be winning the battle of the day, you're not going to win the war. These microbes have been around on this planet for much longer than we have, and they will be here much longer beyond us. And if we continue to escalate this arms race, where we're using more and more antibiotics all the time, increasing that pressure on these pathogens, they do one of 2 things. They either replicate, or they start to come up with different variants. And that means that we need to come up with different antibiotics. And we're running out of newer and better antibiotics. So the only way we're going to be able to win this war is by the judicious use of antibiotics. And in dentistry, there's only 3 reasons to ever write that prescription. But again, I'll let my colleague chime in here.
I love where Howard started the discussion.
Will you repeat the 3? I'm the world's slowest typer.
Sure. So there's 2 prophylactic indications. The first prophylactic indication is for cardiac patients. So, and then you can just go on the ADA website. It's very clear. We only have 4 compelling cardiac indications for prophylaxis. The second indication is also for prophylaxis, but this is in our immunosuppressed patients. So that could be, your fragile type 1 diabetic. It could be your rheumatoid arthritis patient. It could be your patient on chemotherapy, those that have received solid organ or bone marrow transplant. Maybe it's your HIV or AIDS patients. So this actually used to be a very small population, but with the advent of medical science, we're seeing more and more people living amongst us in their immunocompromised situation.
So 2 are for prophylactic. That's cardiac and immunocompromised. Is
Correct,
that the word you use? Immunocompromised?
Yeah, immunocompromised.
Immunocompromised. Okay. And then
Mm-hmm.
The third's for treatment. So if somebody actually has an orofacial infection, then they're going to need the right drug for the right bug.
Hey, Howard, I love where you started the discussion, which is a CYA approach to prescribing, pain pills and antibiotics. A great example of this is antibiotic prescribing for implants, because I don't know how many colleagues of mine, whenever they place an implant, they're always giving amoxicillin, even preoperatively, preemptively. And the data is pretty clear that most healthy patients and healthy sites, it's not needed. I mean, there's been Cochrane reviews, systematic reviews, meta-analyses that say that, but yet we do this CYA prescribing. And I don't know where I heard it, but the saying goes, up front, it's a diagnosis. After the fact, it's an excuse. So a lot of people will prescribe thinking, hey, I just got to do this because if they come back in pain, they're going to ask, hey, why didn't you prescribe some antibiotics and pain meds? And then what are you going to do? Backpedal and say, oh, I'm sorry, I should have done this. But no, we should be following evidence-based, which says we don't need to, in most cases, give antibiotics up front for the reasons that Mark has just told us. Hey, it's a little arms race that we're ultimately going to lose, and we need to be better stewards of antibiotic prescribing.
But, if you ever question anything, you build these movements where you're not even allowed to discuss the pros and cons. Like you're living through it now with Marilyn Manson, who took Marilyn Monroe's name and Charles Manson's name, combined it together. Now he's accused of all these horrendous things. But you got to be wondering, yeah, but you were dating Marilyn Manson? I mean, isn't it, that's kind of a red flag if something's wrong. And the red flag among all my homies that don't agree with you on this, they're all in the Midwest agriculture area, and they see that 70% of all the antibiotics sold are using animals. And so, again, it's like, they took away menthol cigarettes, and Biden just closed down the Alaskan pipeline connection. But how many of the people that took that option away traded in their SUV for a bicycle or walking to work, or, they didn't change in their individual behaviors. And again, it's like, okay, the small 30% of the people are going to have to pay the price because the 70% of the farmers, I grew up in Kansas. I mean, you know how many times Grandpa said, well, you know what you should take? Here, come out in the barn. And he come out in the barn, take out like a wafer of penicillin tablet and smack it with a hammer and break it up into chunks and say, take a chunk of, so what do you say about the 70% of the farm animals where these same microbes and viruses and fungi and eukaryotes, they're all going to do all these nasty things in the laboratory of the chicken and the cow and everything we're eating?
Yeah, I mean, you're exactly right. I mean, let's face it. We're not saying here that dentistry is the only culprit. This arms race that has come to pass is actually due to a number of things. So first is certainly our food cycle. As we introduce antibiotics into animals, livestock that we ultimately end up eating, then more antibiotics are getting into our system. And so there are some safeguards around that, but it still continues to happen. I would point out some very other unique things which people forget about. And that's our ability to travel worldwide on a dime. Now, outside of this current pandemic, it wasn't unheard of to wake up in, South Africa one morning and be in, New York within 24-hour period. And so with this idea of international travel, you also have the ability to take microbes from areas where they historically have not been endemic to, spreading them across the globe very, very quickly. On top of that, you look at other advances, let's say in medicine, where we're able to save and extend people's lives by doing much more types of microsurgeries, implants, those types of very invasive medical procedures, putting foreign devices into parts of the body that they never used to get in before. And what that allows, again, is access for these microbes to get into places where they never used to. So it's a challenge. It's a balancing act, and definitely, dentists, they have some skin in the game here. But so do my primary prescribers in the hospital environment. Veterinarians definitely do. They do in fact have access to the exact same antibiotics, oftentimes in different, even sometimes bigger doses. And your example of your grandfather giving you that wafer penicillin, I'm sure that kind of stuff still continues to happen. So as long as we can increase the overall general knowledge around how important these antibiotics are, and if we could use them more judiciously, a more targeted approach, then they will continue to be very good therapies for us. And if we don't, then we are going to struggle. And maybe that also is a time for us to reflect in the middle of this pandemic. How much worse could it have been if we didn't have some of the tools in our toolkit that we've been able to put in place in order to sort of combat this most recent pandemic.
And I have a question. It's not for me. Obviously, I absolutely know the answer, but just in case someone didn't. Some people throw around the word antibiotic and use it interchangeably with antimicrobial. What's the? I'm just kidding. I don't know the answer. What is the? You're a you got a doctorate in pharmacy. You should know that answer. What is?
Well, I think you just look at the suffix of the word, right? So antimicrobial is going to be against microbes, and those do, for the most part, tend to be bacteria, which is where the term antibacterial comes from. But we do have a lot of other microbes that are out there. I think one of the other challenges, if you think back to your limited time, my limited time too, in microbiology, we always seem to put these bacteria into a singular class. We've got bacteria, we've got fungi, and then we've got viruses. But I think sometimes we forget that within that bacterial class, you've actually got gram-positives, gram-negatives, facultative anaerobes. And so things are a little bit more challenging, but the two words typically are used interchangeably. And as we say in pharmacy, close enough. We don't actually say that in pharmacy.
Yeah. Howard, I want to this is the time Mark knows this. He knows what I'm going to say because I say it so often. This is the time I get on my soapbox because one of the most common antimicrobials we use in dentistry is called chlorhexidine. I mean, that is very ubiquitous in the dental office. We use it as a part of our rinses, and it's a part of our restorative protocols sometimes. But the point is, did you know that chlorhexidine has some very serious allergic concerns? In fact, the FDA has given a very serious warning about it. The UK and EU, their equivalent bodies, have done the same because allergy with chlorhexidine is a real thing and it's life-threatening. And the two cases that I'm thinking of were two patients that died when dentists irrigated an extraction socket with chlorhexidine. Patients had anaphylactic reactions and died. So don't discount that the most common antimicrobial we use in the dental office has some very serious concerns. And we shouldn't just be giving it out as soon as people have bleeding gums. We should be and the worst part really is, and Mark knows, he's probably shaking his head because he's heard this story so many times, is that when you give somebody a Paradex rinse and they call the next day and they say, or the 2 days later, and they say, Doc, since you gave me that rinse, I've had this rash on my back and on the back of my legs. Could that have anything to do with the rinse you just gave me? And of course, the first thing out of our mouth is going to be, well, no, because I gave you something for in your mouth. Why would you have a rash on your back? Maybe you changed your detergent or some kind of product you're using. But no, in fact, chlorhexidine allergy does actually present as a rash on your back and on the back of your legs or arms most of the time. And it can be very serious. So, maybe just a PSA for everybody that gives out chlorhexidine. I mean, I do too, because it's a wonderful antimicrobial, but we just need to be aware of the fact that, hey, with that great power comes great responsibility. We need to be aware of it.
Wow. That's serious stuff. Serious stuff. And I've also noticed in my 30 years that anytime a dentist has a patient die from their work, they're never happy again in dentistry. I mean, they're just never, ever happy. And that's why I've always advised against in-office IV sedation. It's like people don't realize they're playing with fire. I mean, every hospital in the United States will not let the doctor doing the bypass or tummy tuck do the anesthesia. And it only happens in dentistry. Joan Rivers, she was just having a little thing off her deal, dead. And when that happens to you, and your patient dies, I'm telling you, doc, yeah, the dental malpractice pays them 1 to 3 million and all that kind of stuff like that, but you're never the same. You're a broken man after you kill someone. And then they're going to take you into court because someone's dead, and they're going to bring out a board-certified MD anesthesiologist who's just going to play with you on the witness stand until everyone in the room knows you're not an anesthesiologist. You went to some Holiday Inn and took a course in a deal, and they say, well, the drugs are safer. You know, we're not just taking them down with narcotics. We got reversal agents and all that. You guys know 100 times more about this than anybody I'm aware of. Do you agree or not that it's a pretty dangerous thing? I mean, you're talking about rinsing an extraction socket with chlorhexidine. Most all dentists would agree that's a pretty low risk thing, and I don't think many of them would be thinking I'm risking my patient's life doing that. But when you put an IV in someone's arm, since I've owned a media company since '94, dental malpractice companies will send me their monthly claims. You know, companies are always giving you all their press releases, trying to get their message out. And anytime the claim is more than $1 million, they have an IV in their arm. I mean, it's not from a root canal that's gone south. Agree or disagree with any of that?
Well, I'll go first, but I know Mark, and I could just tell you, Mark's been involved in a lot of these cases in the United States and informing some of these regulations in Canada. So I definitely want to get his take. But I think it's really important because we spoke about drugs, is that there's, when you think about drugs as a whole, drugs aren't necessarily dangerous or safe. It's really in the way that you use them. And I think you hit on the biggest point when you mentioned sedation in the dental office. It's about training. It's about using the right drugs. It's probably all about picking the right patients, but it's also around the right people. And when we think about minimal sedation, nitrous oxide, yeah, the dentist can be the anesthetist or the sedationist. But when you bring in those deeper levels, 110% agree that you do not want to be the sedationist, anesthetist. You need other people around to help. And that's really the first step in a lot of this, is setting up all those rights: right patient, right drug, right team, right monitoring, right education, right people. That's where it's all about. So yeah, definitely, Mark, I want to hand it off to you.
Yeah, well, I mean, I'll just echo one of the brightest minds. I don't know if he's probably even been on your show, but Stan Malamed, right? I mean, known very well in dental circles for emergency. Yeah. So he, what does he say the 3 most important things in dentistry are? Airway, airway, airway. And so when you do start to talk, Howard, about these deeper levels of sedation, deep sedation, IV sedation, general anesthesia, yeah, the reason they are challenging and the reason you can't be the operator and the anesthetist at the same time is because you really are the person that's breathing for that patient. When Jason and I get involved with teaching, and we've got a fantastic continuum available right now through the Dentaltown CE, that's us focusing on the lightest level of sedation, where we're not going to be impacting airway. Because as soon as you do start to give these bigger doses, mixed cocktails, IV sedation, you definitely are getting into a much deeper level of sedation than you can truly learn in the course of a weekend. And of course, one of the bad things with all of these cases that are out there where you do have to have a death in dentistry or any profession is the knee-jerk reaction is the regulators take yet another thing away from you. I think that the nice part about these lightest levels of sedation that we teach around minimal adult oral sedation in particular is that, it's such a safe place for our patients to be because they're not asleep. They have all their own protected reflexes. They're still breathing for themselves. They're in constant verbal communication with you. But definitely as you get into those higher levels of sedation, utilizing multiple medications in many cases, it takes on a lot more risk. And I really like what Jason said. any of us can pick the wrong patient on the wrong day with the wrong drug. The most important thing we can do is know when to pass, and we don't have to treat all patients all the time. Sometimes the best place to treat a patient is not necessarily your office, and then you have to be a confident enough clinician to recognize that that you can't be all things to all people. We have specialists for a reason.
Yeah. The dental anesthesia group, they just received their specialty recognition a couple of years ago. I mean, we have endodontists and pedodontists and periodontists. Seek out the best possible person to help you with a case like that. And Mark, like perfect, is maybe not your office. Maybe it's a hospital or more, a controlled environment. But yeah, sedation's a wonderful thing. And, we don't want to lose it. We need to make sure we're doing it the right way. It benefits everybody, most importantly, the patient when we do that.
Yeah.
Nice. So we talked about IV sedation, and again, I live in Ahwatukee. It's the southernmost part of Phoenix, and it's Phoenix, Arizona. Phoenix annexed a long time ago. But if you ask anyone in Ahwatukee, do you live in Phoenix? They say, no, I live in Ahwatukee. And we only have one oral surgeon, and he is an anesthesiologist, and he did it because not only safety, but the practice management of it, it saves him so much time. He can be doing an exam, removing a suture, doing a consult, and then when he walks in the room, they're all draped under, ready to go. He pops out 4 whizzies and it's gone. It's it just doesn't make sense. And my gosh, it just doesn't make sense at all. So let's take that and keep running. I loved your Mythbusters for local anesthesia, and there's just nothing more frustrating when you're trying to do a root canal and they keep raising their hand or they keep feeling it, have impacted wisdom teeth. And I know that you talk about Malamed. I mean, everyone's been talking about, well, doesn't Septicane cause more paresthesias? I mean, that's just something that won't go away. But what are the Mythbusters of local anesthesia? And for the kids that are coming out of school and getting their first job and they can't get someone numb, what would you tell these young kids?
Well, Howard, I don't think you could have set me up any better. I mean, how much time do we have? Because, I think when you're in dentistry long enough, like you and I are, we know that 2 things I think you mentioned. You have to make the experience of getting local anesthesia better, and you have to make the success better. And we also know that if you get known in your town or wherever you practice as the person who gives terrible local anesthetic shots, that's a practice killer. The reverse is also true. You get known as the guy who gives the best painless local anesthetic, that's a practice builder. Right? So there's so much to talk about local anesthesia. And I mentioned chlorhexidine just a minute ago, right? What is the most commonly used drug in our practice, our dental practice? It's local anesthesia. We give it every single day. And I really came up with this idea of local anesthetic Mythbusters to talk about things like, hey, does Septicane cause more paresthesias? Does warming your local anesthetic before you give it make it more comfortable? Is there a local anesthetic that is less painful to inject? Yes, there are. Yes, there is. It's called Prilocaine, by the way. Does a smaller needle hurt less than a larger needle? Does vibration or the wiggly finger actually do anything other than distract the patient? So all these things working towards making it a better patient experience, but also making it work better. I mean, look at buffering of local anesthesia. It was on the cover of JADA a couple of years ago. But we know that buffer anesthesia works better and may actually be less painful upon injection to a patient. So, how can we do what we do better? Because at the end of the day, right, isn't dentistry just there's a lot of different dentists and patients can go wherever they want. But if you're the type of person who gives painless injections, painless dentistry, and by the way, you also do awesome dentistry, right? I mean, I just feel like that's a win-win.
And back to the mouthwash, the chlorhexidine. She wouldn't have died. The patient wouldn't have died if they would have had an EpiPen, right? I mean, isn't that?
I mean, anaphylaxis presents so many different ways, but absolutely. And Mark and I, this is another hot button topic for the 2 of us, because when we talk about sedation or we talk about chlorhexidine allergies, we also bring in this idea of preparedness. Do you have the right drugs in your emergency kit, and do you know how to use them? I mean, have you ever opened up an EpiPen and actually do you know how to use it? That's not the time to learn how to use it when somebody's having a problem. So we're big into being prepared and having the right drugs and knowing how to use them. But in a lot of these cases, if dental offices are properly prepared, right? They can manage a lot of this stuff until help arrives. And the right answer is always call 911. And then there's a third case about chlorhexidine that I always think about, the two of extraction sockets. There was a third dentist that had anaphylaxis because I don't know why he was doing this, but he put chlorhexidine solution on a rag and was cleaning a hard surface as a disinfectant. And he breathed in the vapors and he actually he survived. But, so there's really concerns. And in that case, actually, his team called 911 immediately and the help arrived and he was fine. But yeah, I mean, that's, again, maybe Mark wants to speak about this because this is something that we're very passionate about. Not only should you have the right drugs in your kit, and it shouldn't be buried in the back of your closet behind all the Seafold towels. You better know where it is and you better know how to use it if the time arises.
Yeah, I mean, it really is. It's like everything, Howard. It's all about practice, practice, practice. And, we always kind of tongue in cheek joke that, at the end of the day, who's the oldest person in the dental office? And it tends oftentimes to be the dentist. So, you don't necessarily have to be the one that's an expert at getting the drugs, calling 911 and doing your PABCs, position, airway, breathing, circulation, definitive care. You want to make sure that your team is up to date with their BLS, ACLS, PALS, whatever it is, because, the life they save may actually be yours. This actually gets back a little bit to the idea of AEDs also, automatic external defibrillators. I know that a lot of the dental boards across the United States, as well as colleges in Canada, there has not yet been consonance amongst all dental offices requiring AEDs. But, does it make sense if we have AEDs in casinos, in elementary schools, in libraries, in supermarkets? Why wouldn't you have an AED in a healthcare provider's office? It just doesn't make sense. Those people that are waiting to be regulated to do so, I think now is the time to get ahead of this curve. Because this is one of those true life-saving machines that really, again, in your hands, it makes the most amount of sense. One of the funny stories, this was actually from Washington State, where they were the first state to regulate and require all dental offices to have an AED present, which makes sense in addition to the dental emergency kit. And then they actually retracted that, not because patients complained, but because an orthodontic group got together and said, why do we have to suffer the burden of having an AED at our office when most of the patients we treat are just kids? And so the board rescinded on the requirement, not realizing that those kids don't drive themselves to the orthodontist office. Oftentimes it's a parent or grandparent. So since then, they have actually gone back and they are one of the leaders now in enforcing the fact that dental offices should carry AEDs. And then as Jason mentioned too, because our focus is always on patient as well as medication safety, that there are really only 7 drugs required in the minimal dental emergency kit. And if you do sedation dentistry, you're going to add 2 more. So you don't need to get yourself locked into a serious drug collection. Have these 7 or 9 drugs and know how to use them, and make sure your staff knows how to dial 911 too.
Wow. So I don't want to leave him hanging in the air about chlorhexidine. There's a herd of 8 billion sapiens. We see it with peanut allergies where, that comedian who's a comedian says, if your son eats a peanut and drops dead, maybe your son wasn't going to make it. Would you say that chlorhexidine is like a peanut allergy? It's just so rare that you continue eating peanuts, or are you saying drop it, stop using it?
Yeah, thank you. I think let's put it back into context because chlorhexidine is used so often that I still think the risk is low, but it's increasing. And why is it the risk of these kinds of allergies increasing? Is because we're exposed to these things so many times. Right? You can go to CVS and buy chlorhexidine hand wash. Chlorhexidine and other products are in our cosmetics and creams. And so it's not usually the first time people get exposed, it's the second time perhaps, or even times after that. And by further exposing people to all these things, we're seeing increased rates of allergy. Now, thankfully with chlorhexidine, it's low. But the reason I mention it is really like a PSA, which is, hey, don't discount people getting rashes in other parts of their body when you give them an oral mouth rinse. I want dentists to understand that there is a risk, small, but to be on the lookout for these things. Howard, I don't know when the last time you prescribed clindamycin is, but we know clindamycin has kind of a bad rap for causing some GI stuff. But every single time, and it doesn't happen that much. I've never had one that I'm prescribing clindamycin for years, but every single time I write a prescription for antibiotics, not just clindamycin, I always warn people, hey, if you get some GI upset and it's worse than what you've experienced or just not getting better, I want to know about it. Right? So maybe when people write a prescription for chlorhexidine, you can kind of get up front and say, hey, if you get any rashes on your body, I want to know about it. And this is just, like we said, it's upfront stuff. Managing things before they become a problem. So again, maybe it's just getting the word out, and appreciate the forum to do it, because when I looked into this issue, Mark and I wrote an article about this several years ago in AGD, General Dentistry. Really, it was just so eye-opening because of how ubiquitous chlorhexidine is. So it's rare. I'm not stopping using chlorhexidine, but I'm also aware of the problem or the potential problem, and I get in front of it.
Well, and I would also just jump in with the analogy, Howard. I know that when you and I are of the same vintage, and when we were growing up, there was no such thing as a latex allergy, right? I mean, I don't know if I'd ever heard of latex allergenicity until the 80s, and now, I mean, it seems that we have a lot of people that are allergic to latex. So it's the same type of thing. It's that overexposure, multiple different entry points from dentistry to cosmetics to other items that are out there. So as more people get exposed to these chemicals, you are going to start to increase the potential for allergenicity.
Address the septicane. I mean, there's some issues that will never die, and I know what you believe, but can you show me the observable evidence? They always blame it on a paresthesia. Is there evidence for that?
Yeah. So, and there's a lot of research, and some of the initial research goes back to Mark's homeland, Canada, where Dan Haas and his group, did some early work where they were able to show that the rate of nerve injury was higher when septicane was used, and it was like 10 million injections, and there were 4 paresthesias, something like. I mean, I'm probably not getting the data right, but I don't have it in front of me. But there was very few in comparison. And it kind of set off this tidal wave of paresthesias and septicane. And then there was lots of other articles to go along with it. But then it became a firestorm, almost like things in JADA. I can think of articles where it would say, hey, if an alternative exists to using septicane for mandibular block, you should do it. And what I always say is, like, hey, dentists aren't the only ones who read our literature. The lawyers do too. And if by chance you have a paresthesia, and oh, by the way, you use septicane, well, you put yourself in legal jeopardy. And now we're back to the CYA argument of which drugs we might want to use. There's a lot of stuff to talk about. And we mentioned Marilyn, and I agree with him. There's really 4 thoughts around why paresthesias occur. But let me just come back to septicane for a bit, because septicane was introduced into the US market in 2000. And there's some data to show that, hey, market share went up very rapidly because we recognized that septicane works great and people started to use it. And then we also saw reports of paresthesia. And we think perhaps there was bias there. Right? People were looking for paresthesias because it had already been reported in Canada. Right? Then it reached a critical mass. I forget what it was, 2006, 2007, where people are using a ton of articaine, septicane, and we're seeing a lot of paresthesias. And then people stopped using articaine. I mean, you can think maybe 2006, 2007, 2008, that's all you heard about was articaine paresthesia. And people started to, the use of articaine started to go down. And oh, by the way, the paresthesia reports started to go down, right? So you follow me, right? Gaining market share, using articaine, increasing number of paresthesias. At some point, people say, oh my gosh, it's a problem, we've got to stop. They stop using articaine and the paresthesias start to go down. Well, guess what? I mean, any dentist who's ever used articaine knows that stuff works. And I don't want to go not using it. So at some point, 2009, 2010, people started using articaine again. And you would imagine if there was a problem with articaine, what would have happened? People started using articaine again. You would expect to see more paresthesias if people are using articaine, but what actually happened? Number of paresthesias continued to go down. So we think that there was a lot of hype around articaine paresthesia. We also think there was a lot of bias. And there's really never been very well done controlled studies looking at this issue. People talk about 4% versus 2%. You have to understand that all local anesthetics are neurotoxic. And when you raise concentration, you raise that percentage. But I don't believe 2% versus 4% has anything to do with it, right? It really, to me, and this is where Dr. Malibin, and we wrote an article, the three of us, Mark, Stan, and I, about emergency medicines a couple of years ago now too. I think Stan and I agree on this, which is the most common cause of local anesthesia, paresthesia in dentistry, historically mandible, historically lingual nerve, tongue, is direct contact of the needle with the lingual nerve. And if you think about how we give a local anesthetic block, right? A lower block. Howard, you've done it thousands, millions of times, right? Start on other side, canine premolar. Aim for the other side, hit bone, reorient, go a little further and inject. Well, guess what you're aiming for when you do that? The lingual nerve. And if you get that electric shock, or even if you don't, what happens to the needle when you hit bone? Right? The needle, instead of being a sharp point, gets a barb on the end. And now you're ripping tissue as you go through. And then, let me just also add on to the fact that the lingual nerve could be a singular fascicle nerve, which means one nerve fiber. If you damage that one nerve fiber, guess what you get? Paresthesia. Multiple nerves in the rest of our body have multiple nerve fibers. You damage a little bit, they regenerate, or they actually can function without that fiber. So that's like the perfect storm, the lingual nerve. And there's no wonder that most of paresthesias occur in the lingual nerve. Now, is there a problem with articaine? I don't think that there's a problem with articaine. Is there a problem with our technique? Potentially. So what I have always said about articaine paresthesia is, I don't believe there's a problem with the drug. I believe there's a problem with our technique. So don't change the drug, change the technique, which is don't cross arch and aim for the lingual nerve when you give your block. Do it a same side technique. Right? Same side technique, hit bone and kind of wiggle around the medial aspect of the mandible. By doing that, you stay away from the lingual nerve and you decrease your chances of trauma. Now, there could be other reasons for paresthesia, right? It could be bleeding in the nerve area. It could be inflammation in the nerve area. There could be a neurotoxicity piece. I think in 2021, I don't think we fully understand it, but I think that direct contact with the lingual nerve is probably where we are right now. Do I think you should be using articaine for a lower block? Yes, because heck yes, it works great. But change the technique, recognizing that lingual nerve is probably the place you need to stay away from. Now, one of the last thing I'll say is when articaine was brought to market by Septidont in 2000, they reported a paresthesia. Now, paresthesia meaning like, hey, anything different than normal. It lasted a little longer than you thought. They reported a paresthesia rate of 1 in 42 patients. Dan Haas, in his first study, talked about 1 in 450, 1 in 500,000. The makers of Orablock, that's Perel, recently, so 1 in 42 by Septidont, 1 in 500,000 by Dan Haas, and Perel, the makers of Orablock, which is a very large maker of articaine outside the United States, they just reported an incidence of paresthesia of 1 in 13 million. So I ask you, Howard, if I told you that the risk is somewhere between 1 in 42 and 1 in 13 million, what's your conclusion? The conclusion is we have no idea how often it happens. But one last thing I want to leave you with. What do you think the chances are of you getting hit by lightning when you step outside your house in Phoenix, Arizona?
Well, I want to say 0, but I'll say 1 in a gazillion.
No, 1 in 760,000. So if you believe the Perel data, 1 in 13 million for an articaine paresthesia, you've got a much better chance of getting hit by lightning. Right? So I don't know if we really know, but to me, the direct contact with the lingual nerve is the answer.
Wow. Fun answer. One of the things, again, I try to bring to this show is I try to get the oldest, almost senile people like us to come on the show together, just to get a bunch of old guys, because I think knowledge has no value unless it's transferable. And I think this podcast thing is a really neat format to transfer information. They do it when they're on the Stairmaster, they're driving all this stuff. And I like to give them perspective. And when I got out of school, I gotta walk you through this. I was born in 62. Do you realize that when I was in high school, definitely in grammar school, when I was at Blessed Sacrament in grammar school or Bishop Carroll High School, every car that went by, you could name it. And people would show off because every once in a while, 10 cars went by. Maybe there's one you didn't know, but you could pretty much name all the cars. Now, when I drive into work, I mean, my God, I could never do it. Same thing with prescriptions. I mean, when I was in dental school, you literally could learn all the drugs that were on your patient chart written out by pencil, and you could do all that in your head. God dang, I couldn't. I mean, it's gone insane, the number of things that your patients are taking. I mean, literally every week you can see something you haven't seen before. So does that kind of make these e-prescribes or electronic things a must? Because when you're writing a prescription and your patients, you enter what they're on, you could never do that in your head. Do you do you think it's going to force the pure number of prescriptions that these people are on? It forced you to do this electronically?
Well, it helps, right? It's another tool in our toolkit. Certainly, it helps with the spelling and handwriting issues that I suffered with for so many years as a young pharmacist. I even if you're a poor typist, at least you're bound to get it correct, especially with the fuzzy logic that's built into most of these programs. But you're right, though, Howard. I mean, I also think that when you think back to those early days where you could memorize, those 10 drugs perhaps that you saw most frequently, even back then, though, we were only focused on those top 10 drugs. We at the time weren't even thinking about, over-the-counter medications or nutraceuticals or herbals or botanicals or, all these other chemicals that people put into their bodies every single day. And then when you layer on top of that, the latest area of medicine, which is known as pharmacogenomics or pharmacogenetics. Now we're starting to actually take a look at the human genome and how different doses of different drugs, prescription, non-prescription, over-the-counter, illicit, herbals, nutraceuticals, how those can also interplay differently with people of a different heritage, a different genetic makeup. So it certainly has become much more interesting. That's probably a nice way to say it. Absolutely much more challenging. I do think that the e-prescribing has two benefits. First, and I wasn't joking, that things are a little bit more legible. That means less prone to mistake or misinterpretation. But I also think that the secondary benefit of electronic health records and e-prescribing is that this more correct data is now being shared, whether that's from your office to my hospital to a surgical daycare center, without the need for transcription and transcription errors. Lastly, of course, there are some phenomenal programs that are built in. You take a look at something like LexiComp or Micromedics. So these are typically third-party products that work in the background to alert the pharmacist, alert the prescriber to a potential drug interaction. And I say potential because these programs do try to be as proactive as possible. So when you put in information, my patient's on these 10 drugs, I want to prescribe these other 2. Could there be a problem? You know right up front whether or not there is a potential problem, and that gives you the chance to write for a different prescription, one that's going to avoid drug interactions. So yeah, I mean, it is certainly a much more complicated world, but the e-prescribing, I think, is trying to improve the overall safety and continuity of care as patients transfer from one healthcare site to another.
Why the most confusing question that I've witnessed in my office and others and questions on Dental Town, it just seems like they change the pre-meds so often that people who got A's in calculus can't even remember what the hell. Number one, do they not understand branding? We had this play out in this corona pandemic. First the media and the government says, well, don't use masks, you selfish bastard. Leave them for the doctors. We need them in the hospitals. And now you have to wear one everywhere you go. It's like, well, that's no way to lead a herd, you idiot. Who the hell is in charge of this? But pre-medding for antibiotics, can't they just get a pre-med dose and leave it for long enough until doctors can remember it?
Well, the good news is since prior to 1997, in fact, even prior to 2007, which are the most recent iterations of the cardiac prophylaxis guidelines from the American Heart Association, even though the guidelines have changed, the drugs have actually stayed the same. So, your bread and butter is still going to be that 2,000 milligrams of amoxicillin, typically 30 to 60 minutes prior to the dental procedure. So there you go. One drug dose has not really changed. There really hasn't been any issues. I think the confusion may come from the fact that a lot of guidelines continue to use brand names for drugs. And so, as you probably know, there are multiple brand names for amoxicillin. So I think if you want to make it easy, always just stick to the generic names. There's only one generic name for almost all drugs. And in this case, it's amoxicillin. And as I said, the dosing has not changed. I will also say that, the American Heart Association has, we actually expect new guidelines to come almost any day, because it has been 13, almost 14 years since we saw an update to the cardiac prophylaxis guidelines. And what I would imagine is going to happen, again, the drugs are not going to change. Amoxicillin is still going to be first line for most patients. But I think the number of patients that we are told to prophylax is going to, again, decrease. I think there are still patients that we prophylax today that, given some newer data, we're going to start to realize that we have probably been needlessly prophylaxing these patients for a lot of years. So that's good news. The other area where I think there's been controversy around about prophylaxis has been in our orthopedic patients. So like Jason, I appreciate the opportunity, the forum here, to remind everybody again that for patients with plates, pins, screws, your orthopedic patients, unless there is some compelling indication, and there's only 8 of them, there is no reason to be pre-medding your orthopedic patients prior to dentistry. That's been made very clear. In fact, that guideline has been in place since 1993. But there have been a lot of other articles that have come out since then to kind of muddy the water a little bit, which is why the cover of JADA in 2017, January 1st, Peter Lockhart and the rest of his colleagues once again clearly stated that for your orthopedic patients, unless they have one of the 8 compelling indications, there is no reason to be prophylaxing your orthopedic patients.
Hey, Mark, I want to say something that I always hear from you, which is don't get yourself locked into a serious drug habit or a closet, which is know the medicines that you're going to prescribe. Keep that list very small. Maybe it's amoxicillin, maybe it's clindamycin, and maybe it's azithromycin on the antibiotic side. On the pain medicine side, maybe you have your standard ibuprofen and acetaminophen, and then a narcotic that you want to add in from time to time. But the benefit of having a small number of drugs you prescribe is that you know when to use them and how to use them, and maybe even most importantly, who not to use them with. So it's not just I need to have all these exotic drugs, the moxifloxacins and, the Dilaudids, or, because you can use those medicines, but are they significantly better than the standards we've used for all these years? No, I mean, keep your drug armamentarium small. And it also goes with your local anesthetic, right? Everybody has lidocaine in their office, probably also have articaine, and then you probably have something without epinephrine and maybe marcaine for long acting. So keep your armamentarium small, and you can understand all those good parts about how to use them, when not to use them, and who shouldn't get them.
Totally agree.
And I want you to explain the title, because a lot of the people that see this podcast might not understand the title that that you guys sent me for the show, which is why Dr. Mark Donaldson, dental pharmacologist at Vizient, and Dr. Jason Goodchild, Premier Dental Products Company, think magic mushrooms are the only pharmaceutical dentistry we'll ever need. Could you kind of clarify your views on that?
Well, Mark, I think you should speak first, because from Canada, you have a little bit more of an open mind towards nutraceuticals, I think, right?
Well, I think the big issue here is that if you do consume more of that psilocybin or magic mushrooms, then obviously dentistry is farthest concern from you. So, maybe that's really what they're talking about.
So you called it a nutraceutical, magic mushrooms?
No, I
don't think I got that right, but it's something. Well, go ahead, Mark.
Psilocybin is the active ingredient of magic mushrooms.
But isn't there's a whole? I mean, you mentioned it before. We have, when it was just other drugs we had to worry about, but now we've got people on herbals and nutritional supplements and natural medications, and we have resources to be able to figure out how these natural medicines may impact our prescription medications, right, Mark?
Yeah, absolutely. I mean, this is one of the challenges, and you've been talking a little bit, Howard, about how your access to certain things have been taken away, starting with menthol cigarettes of late. Actually, that was preceded by flavored e-cigarettes several months ago, which you may not be aware of. But the fact of the matter is that what is happening across this country is increased access to medical as well as recreational marijuana. And so, they take away some things, but they're giving you others. And this is becoming a challenge for dentists, especially because you are starting to see more and more patients experimenting with uncontrolled substances like marijuana, and that of course is a drug that's going to interact with some of the medications that we use in medicine and dentistry. So it definitely is a challenging milieu that's out there.
Yeah, and my whole deal with all that is just very simple. I mean Kevorkian proved it. I mean, he, you have your rights, and I just look at 5,000 years of history, and it's always the individual has to do whatever the surface, it's just geometry. I mean, one person can't is at a different place than the macro. I mean, you got the individual and you got the big macro, and I get that, but I just think they should meet in the middle. And it's always the case of the macro telling you, we don't care about you. What we think is more important. And it's the same human being with the same damn brain who's usually 1,000 miles away and doesn't know your situation. And the red flag is they just always take away your options. It's always someone with 5 options is taking away the only option that one guy has. And like minimum wage. Okay, so you're so damn poor, you would gladly do this job for $10 an hour, but you don't even have the right to do that because the macro people said, no, everybody's going to get 15. Yeah, but I got a really special case. I got all these situations, and I want that job. Now I'm willing to do it for 10. Well, I don't care what you're willing to do. I'm 1,000 miles away, and I know more than you. And it just gets so old and exhausting and tiresome to do all that, to listen to people, always taking away your rights. So my gosh, I can't believe we went over an hour. But back to the marijuana legalization, it was the overaction. I mean, you caught people with this weed, and in Texas, they locked people. They gave. You know how many people right now are in Texas that got a 100-year sentence because they had a whole bale of hay in their deal? 100 years for doing something dumb? I wish every dentist in America had to make a video on the dumbest thing they ever did in their life. I mean, if you never did anything dumb, you're never been a drunk Irishman. My gosh,
Mark, you understand that. You're from Scotland, so you understand that, right? Drunk Scottish?
I've had some history there, yeah.
My gosh, is there? I'm trying to think if there's. I want to ask this. I know we're out of time and we've gone over. I still got a couple. Do you mind if a couple overtime questions?
Absolutely, sure. Go ahead.
Because of the pushback on narcotics, and now people just don't want to do it. I just noticed it the other day. The child had a toothache and said, well, did you give her anything for the pain? And she said, yeah, I give her Motrin, and I gave her Motrin and Tylenol. I didn't know which one I should give, so I was given both. So now we really got to know what's going on with Motrin and Tylenol and aspirin and Aleve, because now, I mean, patients are playing with that and combinations. I like Tylenol. Tylenol is owned by Johnson & Johnson. They set aside $1 billion a year just for all the lawsuits they're going to get of people that died. They went out and got hammered, and then they took Tylenol, and then the argument against it was, well, why do you make it 1,000 milligram extra strength? Because when you're drunk, you're going to think, well, if one works, 2 will be better, and I don't want to wake up with a hangover. So they pop 2 big old extra strength Tylenols, and they're drunk, and they go to bed, and they die the next day. That happened to one of my employees, next door neighbors, and it was just heartbreaking. But could you kind of give us an update on those over-the-counter, all that, since in a post-narcotic world, we're going to start seeing a lot more of this stuff with the over-the-counter?
Sure, I'll start, Jason, if you want. So the first thing I think, which is easiest, and you brought up so many great points there, Howard, is working in the language of generic names is probably the best way to go, because when you say ibuprofen, then we're all working apples to apples. If you say Motrin, then suddenly that's a form of ibuprofen, similar to Aleve being another form of ibuprofen. So you can have lots of different trade names or brand names for the same active drug. And that's one of the things I always counsel patients on, that if I'm going to prescribe ibuprofen for you, it means you take my prescription and you don't go home home and take my prescription as well as some Motrin or Aleve or Nuprin or whatever else you have going, because actually the active ingredient in all those is exactly the same. It's all ibuprofen. So the same thing could be said for acetaminophen. Tylenol is the most well-known brand name, but there are other brand name over-the-counter medications that contain acetaminophen. Now, I think the other important piece that you brought up is we do in fact have maximum recommended daily doses, or MRDs. And for Tylenol, as of this moment in time, for an otherwise healthy adult, it's 4,000 milligrams in a 24-hour period. So essentially an extra strength Tylenol, which is 500 milligrams, if you took 2 of those 4 times a day, you're at the maximum of 4,000 milligrams in a 24-hour period. So it is pretty easy to get to those maximums. So not only should clinicians be good prescribers, the right drug, right dose for the right patient, the right procedure, but also know those maximum recommended doses. And encouraging patients that when you write prescriptions, not to simply take your prescriptions and augment themselves with other drugs that they may have at home. They really just need to take your drugs as prescribed and not help themselves to additions, because then they can very quickly get above that maximum recommended daily dose. So again, for an otherwise healthy adult, especially for acute pain secondary to dentistry, 4,000 milligrams of acetaminophen a day coupled with 2,400 milligrams of ibuprofen, that really is the best sort of combination strategy right now, and that keeps you underneath the current maximum recommended daily doses for both of those drugs. I think one of the other sort of falsities out there, or things that people fall into, is the idea that, well, if it's available over the counter, in other words, without a prescription, these drugs must be safe. And all drugs are safe, but if you pick the wrong patient on the wrong day, or you give the wrong dose, suddenly they can become a lot less safe. And so maximum recommended doses are certainly something that we want to enforce and make sure our patients stay below that and not mix these drugs with the prescriptions that we know work. Jason, what else did I miss there?
Howard, I want to tell you a quick story, because Mark and I are working on some stuff right now. We're looking at the history of opioids, and why do we have so many different opioids in the U.S. pharmacopoeia? Well, listen, opium, thousands of years being used in medicine. The first isolated form of opium was morphine in 1803. Then in 1830, there was codeine. The first fully synthetic opioid was meperidine or Demerol in 1939. And then what about oxycodone, hydrocodone, hydromorphone, all the others? Why do we have all those narcotics? And I think when you think about, we recognize that these drugs were abused. They were abused during the U.S. Civil War. There was a term for it, like, soldier's disease, essentially, because they got hooked on morphine and codeine as a part of being injured in the war. But why did we develop all those other forms of narcotics? Well, because we were searching for something that worked as good and it wasn't as addictive. And OxyContin, long-acting form of oxycodone, was actually marketed that way. When it came out, it was actually marketed as a more effective and less addictive medication than oxycodone or other narcotics. So we were always searching for the next best thing. And what we realized was that all narcotics are drugs of abuse. Now, we're actually looking at a specific drug called tramadol, which goes by the name Ultram, because Ultram or tramadol is a narcotic, but it wasn't a scheduled drug by the DEA for about the first 20 years that was available to the US market. Right, so we've always been on this search for the next best thing. But you know what we've come? We've come almost full circle, right? The current prescribing guidelines for pain and dentistry, ibuprofen and acetaminophen. And then what's the next one? Hydrocodone or oxycodone. So we're not trying to get exotic and trying to find something that's less addictive. We're recognizing that, hey, what actually works? Just try to make it into a bit of an algorithm. If it's not working with this ibuprofen and Tylenol, then you go to higher doses on schedule. Then maybe you add in a narcotic. And you know what the most important thing is? The shortest amount of time, which is exposing those folks, not just with antibiotics, but with pain meds, to the shortest dose regimen you can. Most people, like you said, 28 tabs of PenVK. Do you need 28? That's 7 days. Can't we get away with 5? Maybe we can get away with 3 in some cases. Do you need 25 Vicodin tablets, or can we get away with 10? So it's like, the idea of minimizing the exposure to these drugs is part of the way we actually prevent some of the side effects as well.
Well said.
Wow, you guys, I love your passion and your deep understanding. I just got to ask one more question because, again, we have a lot of kids at school, and it's a lot easier to learn algebra than it is to explain things to patients. And they're going to routinely get the question about substitution versus generics. My pharmacy friends say they get it all the time. Is there any time when you say, no, only get Budweiser? You don't want to save any money and get a Miller? No. Is there any time that that they really need to say no substitution permitted, brand name only? What are your thoughts on that question?
Yeah, really, the only time that people need to stick with a brand name is if it's working for them and they have tried a less expensive generic medication and it hasn't worked as well, or they've had some type of adverse reaction to it. But in most cases, when you look at the regulations, the letter of the law, the generics have to be within 95% potency and purity of the brand name. So 95% is pretty close, but that does mean that there's a potential that 5% of the time, some people might not react to the generic medication as well as they have reacted to the brand medication. So I would say, I'm very comfortable taking generic medications, probably because I'm Scottish, always looking to be as economical as possible. But there could be, let's say, 5% of cases where it does make sense that if they're on the brand name and it's working for them, if it's not broken, why fix it?
Hey, Mark, let me set you up for one more question, Howard. If you allow me, I'll ask Mark a question, which is we hear all the time, folks ask us, hey, we can prescribe 600, 800 milligrams of ibuprofen, but can't we just have patients take 3 or 4 of the over-the-counter ones? And is there really a difference between prescription ibuprofen and the stuff you just get in the pound bottles from Costco? And I think there's some new interesting research. So I just wanted to ask Mark about this because I think that's an interesting question.
Yeah, and you're exactly right. At the end of the day, as we've been saying, look at the generic name. It's ibuprofen. It doesn't matter what formulation it comes in. It's still the same active ingredient. And what studies have actually shown, a recent one out of the Oregon Health Sciences University in Portland, Oregon, they took patients and gave them 3 of the 200 milligram over-the-counter tablets of ibuprofen and did blood levels as well as pain scale measurements compared to people that took the prescription strength, that big orange horse pill, 600 milligrams of ibuprofen. And what they actually found was that the 3 of the over-the-counter 200 milligram tablets worked better. And part of their conclusion was probably surface area. So the 3 200 milligram tablets have a much larger surface area, which means dissolution through the gastrointestinal tract as the tablets make their way to the small intestine where they're absorbed. More of the drug was absorbed because the dissolution was better, and that led to higher blood levels and better pain management versus the singular 600 milligram orange horse pill when you try to swallow and dissolve that in enough time for it to be absorbed in the small intestine. So yeah, great question.
And one last thing. I know, I don't want to get into the debate about addiction because we're dentists, we're not addictionologists, but I still find it hard to believe that you could go get a prescription for Vicodin, and the next thing you know, you're a heroin addict. I mean, it's the same thing. Did you become an alcoholic after your first beer? I think humans are incredibly complex, and it's multivariate, and there's a lot going on there. So don't be an extremist view, like yes, no. But I want to say another thing about opioids is that in my 30 years, if you're a dentist and you get addicted to these things, and the DEA knocks on your door, 30 years ago, it was treated as your criminal behavior and lock them up and throw them away, whatever. That's completely changed now. The only time it backfires is you're a liar. And God dang it, when the DEA knocks on your door, they're not going to knock on your door if they don't know exactly 1,000 reasons why they should be knocking on your door. And everybody just says, lifts up their hand and say, busted, I'm sorry, I can't quit doing this. Like, we got it. And you'll go into some 5-year peanut cut program, whatever. But the ones who lie, you're going to end up in a cage, buddy. Just don't do it. It's the same thing with the anesthetic overdoses I've seen, where the hygienist comes in and numbs up the kid for a bunch of chrome silk crowns, and then the dentist gets there, and he didn't know you did that, and he re-numbs up a little pedo patient, and they die. And it's a horrible thing. But the doctor going in and changing the notes turned it from a civil board, now it's a criminal thing with the federal government, and you find yourself sitting in a cage. So, rule number, it's like Clinton. When Clinton got busted with Monica, if he just would have said, hey, why don't you be married to Hillary for 30 years and tell me how that works, everybody would have said, oh, yeah. It would have been over. But he lied. He said, I did not have relations with Monica or whatever. And by the way, I lectured in Poland right after that. And Monica was on every billboard. Only this product is good enough to touch my lips. And every dentist was nudging me saying, hey, see, your president likes Polish girls. They were so proud of it. So it's funny. And then the last thing is this. It's pretty stupid when you lose your license because your girls were ordering their birth control pills out of the Shine catalog, but I certainly know a dentist where that happened to. And he was thinking, it's a birth control pill. It should be legal. You should buy it over the counter. I know all of that. I agree with all of that, but that's not how the party rolls, dude. You got 331 million humans in this herd of sapien cattle in North America called the United States, and there are rules, and you can't write prescriptions for your staff for birth control pills and all these things like that. Don't be loose. And here's the wording that you say, because I know if you just have a wording, it helps. When a patient asks you to write something that's not in your line of scope, hell, I've had a patient ask me for Viagra once, and I mean, crazy stuff. You just laugh and say, "Oh, that right," but I mean, you obviously wouldn't want me to risk my license over this. I mean, I went to college for 9 years. I mean, I know you wouldn't want me to risk 9 years of my life for something this ridiculous. And they always say, oh yeah, no, I didn't mean that, even though they just meant that. They just asked a specific question. So any thoughts on what I just said about that rant?
Go ahead, Jason.
Well, no, I just can't agree more, Howard. I mean, it's because the thought is, well, what's the harm? What's the harm in writing that prescription for the birth control pills? Or what's the harm in writing that antibiotic prescription for your patient? They're not infected, but, just CYA. What's the harm? But there is a lot of harm because, honestly, when we keep our scope small, keep our antibiotic prescribing scope small, like I said, we know when to give it, who to give it to, and when not to give it to. When we write another prescription, Mark will call it the power of the pen, right? I don't know. Are we really recognizing the right patient to give the right drug to? So I'm right with you, and I'm going to give it off to Mark because he's a pharmacist. I'm just another prescriber, just like you, Howard, and I get those same questions, and I think, hey, what's the harm? But you're right. We've gone to school for too many years, spent too much money and time to jeopardize our professional license over something so silly.
Yeah, and that is probably the best final word right there. That if you have the opportunity to do something correctly the first time, why would you not want to take that opportunity? So we've talked about analgesics, antibiotics. We've touched upon the fact that there are very clear guidelines on appropriate prescribing practices. The passion that Jason and I have and the teaching that we do is really around trying to keep our dental colleagues safe and by staying within the guardrails, and being aware and staying up to date and listening like your listeners are doing right now to the latest and greatest. I think that's what's going to protect you at the end of the day. And Jason did say it very clearly earlier, whether we like it or not, the lawyers have access to the exact same guidelines that we do. And so it really does behoove us to always, to take advantage of doing the right thing first time, every time.
And I just want to, the last question, but before I do this, every time you guys put out a course, every time, since we started this show, which was, when did we figure out when the thing started?
2016, yeah, 14,
2016
I think, right?
Or whatever. Every time you guys put out a course, when are you going to podcast? When are you going to podcast? I mean, I've been inviting you guys for years. They love it so much. But the final question I have is just for me. Last question is there, you work at Vizient. Is there any, what is the direct dental connection between Vizient and dentistry?
No direct link right now. Dentistry has its own group purchasing organizations. You already mentioned Henry Schein, Straumann, others like it. So we perform a similar function, but my personal connection, my father was a dentist. He's actually credited with bringing the use of IV diazepam from Scotland to Canada for in-office use as a dentist. So I grew up in a dental household, and while he never encouraged me to go into dentistry, he always said that if you want to go into the health sciences, if you want to become a doctor or a vet, on the way there, you might want to go through pharmacy, because a lot of his colleagues were excellent clinicians, but didn't have a strong grounding in pharmacology. And I found that when I went through pharmacy school, I had a strong passion for it, strong affinity for it. And as I work with dentists and other prescribers, I realized that, pharmacy is actually interesting. It's just typically taught poorly. So if I can teach it in a clinically useful manner and make it a little bit more applicable to you and your ability to improve care on Monday morning at chairside, then that's what I want to be a part of. So that's really how I fell into it.
One more thing, Howard, can I just add? Mark and I have been teaching together for over 20 years. And when we mentioned programs like LexiComp or Micromedics or ways we can help to distill out what we need to know for pharmacology, I have all those things at my disposal. But you know what else I have? I have Mark's cell phone number, which is I can phone a friend. And one of the things that I think is also really important is to build those professional bridges. The hospital pharmacists at the hospital, or the retail pharmacists at a CVS, Walgreens, Walmart kind of thing, or just friends that you have. We can't know it all, and we're smarter when we bring in other people with expertise other than ours. And so I've just been so grateful and blessed to be able to work with Mark for the past 20 years. He calls me his best student because, after all these years, I think I've absorbed some of it and I can speak the language a little bit, but it's been a truly just an unbelievable partnership, be able to do the education and hopefully he's gotten as much out of it as I have. And it's been awesome.
Yeah, absolutely. Not only a great partnership, but a great friendship. So it's, and it'll continue on.
Well, thank you guys for all that you've done, not only for dentistry, but for Dental Town. I mean, your 6 courses, I mean, they're legendary. And thank you so much for coming on the show and explaining all the issues with this subject. So thanks a lot. And I hope you guys have a great day.
Yeah.
Thanks, Howard.